So good afternoon, everyone. It is 12 noon, and it is my pleasure today to have our skills building webinar series. My name is Deborah Levine. I'm the director of the Harlem Health Initiative for the SUNY School of Public Health and Health Policy. And we are honored and privileged to be able to bring to you today our skills building lunch series. Today's topic is technology applications and augmentations of mental health treatment and outcomes. And Dr. Marie Salis will be presenting this morning. And this will go for an hour. We'll make sure that we leave you plenty of time for questions and answers. This presentation will also be recorded, and you'll be able to find the recording on our YouTube page, and we will also send out a link for you to be able to share with your colleagues. We also ask at the end that you fill out a brief poll for us so that you will help us as we continue to guide and create new programming as we move into the summer and our new normal. So without further ado, please remember to keep yourselves muted. If you'd like to ask questions, please use the chat. I'll be happy to facilitate any questions. So without further ado, I will decrease so that my colleague can increase and share her knowledge. And we are also grateful for her coming and sharing the information today. Thank you.
Well, thank you so much. I want to thank Deborah Levine, the Harlem Initiative program for inviting me to speak here today. I want to thank you all for joining. A little bit about me before I start. I am trained as a clinical psychologist, meaning I am a researcher and a clinician. As a result, I look at the state of our mental health care system in terms in looking at public health concerns and ways we have to address public health concerns. So the state of our mental health care system and various barriers, how we can address them to increase wide access to mental health care, but access to evidence-based care, and how do we address language and culture and an assessment and delivery of care, and what are some ways we can really tap into to increase and integrative care, which we know is much more successful in promoting outcome. So for this presentation, I will go over why mental health is the role of mental health within public health, and why is it a public health concern, and why should we be concerned with treatment. I will also go over treatment, overview of a treatment approach and limitation to current standards of treatment that are impacting access to care in integrative care. And I will address some technologies that could be potentially viable in augmenting care by increased dissemination and access to care, particularly evidence-based care. And what is a platform, common platform that is being used in other areas that could advance how we deliver integrative care. And lastly, I'll go over some of the limitations of technology-based intervention-based programs and how research need to iron certain limitations out in order to integrate them potentially in clinical setting. So we know healthcare is a public health concern, and I know that I'm sure the audience is very diverse, so you may not be clinicians. So let's talk about what we mean about mental health disorders, psychiatric disorders, and why should it be a public health concern. So mental health, psychiatric disorders is basically maladaptive patterns that lead to significant dysfunction in various aspects of an individual's lives. This is a result of significant disturbance in thinking patterns, and these factors, thinking, thoughts, and behaviors, these interact to impact different level of functioning. One of the reasons we should be concerned within public health, we should be concerned especially as clinicians, because we know the prevalence of mental health disorders among our US population, according to the most recent report, a 2019 report. When we look at serious mental illness, and there's some psychiatric disorders that have been deemed as serious mental illness because they have shown to have very serious impact in various areas of dysfunction. However, there is some disagreement in the literature that all mental health disorders have impact. However, but there's ample other data to show that serious mental illness, for example, as schizophrenia, major depressive disorder, bipolar disorder, tend to have very serious impact on one or more areas of dysfunction, functioning rather. And we know slightly over, a little bit over 13 million of adults experienced SMI in 2019. In order the importance of understanding mental health and mental health care and access is because we know among psychiatric population, life expectancy is reduced. And part of it is because of that reduced expectancy can be partially explained by high risk for various chronic disease that we see that are more prevalent among psychiatric population, including these like, for example, heart disease and obesity. Although I do have to address that obesity at times is associated with psychotropic medication that are used to treat, because mental illness is treated with psychotherapy and pharmacology. And so some of the antipsychotic medication, atypical antipsychotic medication that are used, for example, in schizophrenia, and they can be used in the context of depression, because within depression, you can have psychosis, that they are associated with weight gain. But they're better, they're used because there's less prevalence for psychomotor issues that we see with other type of antipsychotic drugs. So another public health concern, is because suicidality is high among people with psychiatric disorders. It's a second leading cause in deaths in ages 10 to 34, and we see in ages 35 to 54. And as you can see on the graph, overall, that shows rates of suicide by race and ethnicity over the course of 2009 and 2018. You're seeing there's an increase overall for groups, although some groups are more elevated than the other. So here is the rationale. So why, and within public health, I guess in any area of life, we should be interested, we should be concerned about public health, and we should be concerned about making sure that people have access to care. So therefore, we have to assess the state of our mental health and mental health treatment. Comorbidity is not just psychiatric disorder and chronic condition, but we see that typically when you treat psychiatric patients, they're not going to present with one psychiatric disorder. It's not just depression. So within that, you have comorbid comorbidity of co-occurring psychiatric disorders that make presentation a bit complex and assessment complex, and therefore treatment approach. In addition, when we have comorbidity of co-occurring psychiatric disorder and medical condition like obesity or type 2 diabetes, we see that there is poor health outcome for these groups. While minority individuals do not have higher prevalence of psychiatric disorder, but we know that minority population like African Americans, Latinx population have disproportionate health conditions. So when we look at minority psychiatric population, this is further burdening them, because we know by having psychiatric disorder, you're at increased risk for developing these conditions, which are already prominent among minority groups, disadvantaged minority groups. So before part of the high risk, that are associated or prevalent among psychiatric population can be partly explained to the physiological impact that certain disorders, the chronicity of this disorder, the experiences associated with it wreak havoc in our body. So how do we understand these risks? So think about anxiety. Whether or not whether you're a clinician or not, you have heard of anxiety and you have heard of experience of anxiety, although it may not be consistent with what's portrayed in the movies, but nevertheless, you have some sense of it. So anxiety, when a person is anxious, clinically anxious, I'm not talking about normal level anxiety is actually normal for our preservation. It makes it work better. It makes us help, meet deadlines, because normal anxiety is actually fine. We're talking about clinical disorders. We're talking about mental health disorder diagnoses. So when you are anxious, the body is reacting as if it's under attack. It's not thinking that, there's nothing in the environment. It's reacting the same way as if you were being chased by a big old animal elephant. It's flight or flight, it's preservation. So as a result, what you have is that your nervous system is impacted. So your endocrine, your cardiovascular and neuroendocrine system overall over time is impacted, because there's certain neurotransmitters that are impacted when you are anxious, because it must prepare you. As a result, your digestive system is impacted, is not functioning properly, because your digestive system and other system that is not going to help you to effectively fly or fight are hindered or impacted, needlessly. So what the body is experiencing, we know, is these reactions from the psychological perception or perceived fear of the situation, but physiologically our body is reacting the same way as if we were under attack. So with chronicity of these symptoms, what you have is that people, our body and minds are constantly on edge. And this is part of the literature explaining why you see a lot of, for example, type 2 diabetes, prevalence of type 2 diabetes rates among people with psychiatric population or hypertension. So treatment, I won't go, like I said before, I'm not going to go over into details about psychiatric treatment, but since we're talking about mental health status, I want to give you an overview of what a treatment approach is. So we kind of have understand what evidence-based treatment should be and why it's important. So I'm a cognitive behavioral therapist, clinician. So from a cognitive behavioral therapy approach, how you are treating psychiatric illness is that there is a stimulus. So the situation is the stimulus that is happening in the environment. So for this example, this person is trying to look for a job online and the computer already stops working. And the automatic thought is that, okay, this is hopeless. And nothing ever goes right. So it's like, overgeneralization of this situation right now to just overall, life. And then we have a behavior, throwing the computer away or stopping, stop looking for jobs. And all of these constructs, so the behavior impact body sensation and therefore emotion. As you can see, there's a direct bidirectional relationship among these factors, meaning that they interact to impact one another. So your behavior, it can impact your thoughts, and emotions can impact the thoughts that you have. The primary interest in the cognitive behavioral psychology is to intervene at the thought level. So the maladaptive thought level is what is helping to maintain these patterns, these psychiatric issues. So if you intervene there, you're much more going to have a better behavior. So if the person is thinking, oh, okay, this is it's just a computer not working, so there might have a more adaptable and more healthier behaviors, not throwing your computer away, because first of all, you're going to be paying for getting a new one. Okay, well, I'll just shut down the computer, or I'll use another friend's computer. So this is, in a nutshell, an approach using cognitive behavioral therapy for treating psychiatric disorders. So standard approaches to treatment within psychiatry, psychology or psychiatry is that the initial assessment, how you diagnose a disorder, or how before, if you're seeking treatment, you have an initial assessment that is conducted typically in person over the phone. Even with COVID, well, the healthcare staff, industry have to really, trying to determine how to deliver care, especially at a time where people were in increased need of care. Telehealth, certain rules, regulation were relaxed, but still it still is a problem for reimbursement. There's certain insurance that do not reimburse or fully reimburse clinicians. So therapy, the delivery of therapy, the standard of it is in person. So traditionally, therapy is usually 30 to 1 hour session and over many months, and symptoms over the course of treatment, assessing, progress or improvement is done in a way that is relied to pass self-report data. For example, how's your depression over the past, 12, past 2 weeks or the past 7 days? Not at all am I saying they're not in the moment, how do you feel now assessment, but typically how we assess the course of symptoms and symptoms improvement is having patients recall data from the past. So think about so we have a traditional way of delivering treatment in person and assessment of treatment in person. Here's the problem with that. Certain places within our country, they do not have a mental health provider. So access to a mental health provider is just not there. A recent part of Snowden, I believe, article looked at care, wait time for receiving care. And among people with psychotic disorders, patients with psychotic disorders, they saw that the median time was 74 weeks. That is a huge issue. Psychotic disorders, by the way, is a characteristic, core features of the disorder is hallucination or delusion. While some patients with psychotic disorder, they're not totally devoid of any reality. However, we know treatment is important. Immediate treatment, access treatment is important, that your symptoms does not worsen. And consistent with access, that even when you have community places where there is access to therapists or to psychologists, whatever the mental health provider, evidence-based treatment is not used. So especially when you look at within low income communities, there is a problem, because we're not, looking at the state of mental health care is not simply access, but access to quality care, therefore evidence-based treatment. An ongoing assessment of evidence-based treatment, even when there are situations where evidence-based treatment is being used, there's also a lack of attention to cultural and linguistic factors that could really help us to understand, to better conduct assessments, or assess presence of certain disorders, and therefore inform treatment. So when you are not paying, the critical juncture we are in mental health delivery is how do we capture culture and relevant linguistic context that really could give us important information, how we assess, how we treat, and therefore how we engage patients and retain them in therapy. Because you cannot, if you have low engagement, the patient is not coming consistently to therapy, you have a dose effect. And therefore, when you have a dose effect, you're not likely to see improvement, and people get annoyed, and and they eventually drop out. So feasibility as it relates to how we're delivering care, which is primarily in an in-person modality, is that even with evidence-based, there's some people for it meeting in person, coming to your clinic, coming to a clinic for every week for many months, it's just not feasible. People have competing demands. So how do we address this barrier and then make healthcare feasible for people by meeting their needs? As I said before, assessment of symptoms, therefore progress of symptoms at times are done by asking patients to recall data, recall how they felt over the past 2 weeks. So they may not be capturing symptoms. And we know it's critical to effectively understand underlying important factors in mental health disorder, how it presents in the patient's experience. We must have ample information, how symptoms, emotion, and all these things co-occur close in time. So think about what you did 2 weeks ago, whether you've had a very stressful or you had you felt very anxious 2 weeks ago. You may not be able to, most of us will not be able to recall details about, okay, what exactly was in the environment, how I felt, how I, led to my behavior, how long with this behavior, I engaged in this behavior. So all of this information, not having this information, it really impacts the quality of treatment, the tailored treatment we're able to provide. And this is an example of the limitation. This is a typical depression scale that asks you how you feel over the past 2 weeks. So part of in assessing, it's a status of mental health care and access to care and quality of care is how fragmented is mental health care. We all know that it is indeed a fragmented. There's limited attention giving to medical conditions and psychotherapy, despite the fact we know people with psychiatric disorders have co-occurring medical condition like type 2 diabetes. Why is this important? Because there's an interactive relationship, for example, with people who has bipolar disorder, which is characterized by high, low, and high, and very highs. Like people are very depressed, and there are a period where they're very depressed, and there is a period when they have just, a high amount of energy, which we call mania or hypomania, if it's bipolar 2. So we see that these destruction, these destruction and functioning, these impact and functioning can impact adherence to medical care. So in medical, if your type 2 diabetes is not well managed, well, it's going to impact your mood. So this interactive relationship could really present a barrier to what we see in outcome in care. The patient is not progressing because we don't know as clinicians that they're not adhering to their, to the medical treatment. So what we're seeing here, the presenting symptoms is not just an indication of the psychiatric disorder, it's also associated with lack of attention or adherence to the medical treatment. And oftentimes, just people do not, clinicians do not have information about history of the patient that will help you to inform diagnoses. Because you go to different providers, and providers really basically work on their own. There's not really a way to have access to patients' information, which can really help you to understand the trajectory of symptoms, the history of symptoms, and type of treatment approaches the patient have not really particularly been receptive to. Things that have not been effective. So therefore you can know, okay, what is, how do you work collaboratively with the patient, with the information that you have to choose the best approach to address presenting symptoms and to treat them effectively. And we know access to current treatment to patient history can really facilitate the delivery of integrative care. And we know the more integrative, the more different resources you are using, information from the PCP, information from the endocrinologist, information from the dietitian, information from the physical therapist can actually inform various underlying factors that work to support lack of progress that you're seeing in psychotherapy. And how do you help address this? How do you address this within the clinical context, the clinical milieu with your patient? So what are some viable technologies, way to augment, to improve access, to improve access to quality care and to make care integrative? One way, recommendations in the literature, is to use technologies to increase dissemination. And the healthy people, which comes every 10 years, really, these are guidelines. They provide guidelines so how we can make increased effect or impact within public health. So mobile technology provide a substantial opportunity to tailor not just behavioral health, but health in general. And it becomes prevalent because we know among psychiatric population, various, unhealthy behavior patterns, chronic physical inactivity, poor eating, it's prevalent, it's high among this population. So how do we use technology to augment care? So here are some technologies that some of us, we use it, we actively use them in our daily lives, and sometimes some of them, it's just passive use of them that can be used to augment care. Quality of care, access to care, assessment of symptoms, and delivery. For example, GPS, geolocation data, where you are, your environment, how can that information be collected that can inform mental health care and tailor treatment to the individual or at the group level as well. Robots are being used in medical care, and they're being used in healthcare to a certain extent. So we'll go over what is the evidence for them. So one of the reasons where the recommendations that use technologies can augment healthcare is because we know saturation, for example, a smartphone. A smartphone has been identified as a potential viable platform for delivering mental health care. It's saturated. The ownership is saturated among demographic groups. So people are already using this platform in their daily lives. Similarly to app usage, we see, high app usage among various age groups. That's another opportunity that we can leverage to augment healthcare, the dissemination of evidence-based care. Right now, there's probably by now over 400,000 mental health apps, and they're being used as assessment to monitor symptoms, to assess symptoms, to monitor symptoms. And however, within the psychiatric care, it's not, apps are not widely used. Also, smartwatches have been identified as a viable platform to not only deliver, to assess various behaviors, but biomarkers, objective measures that we can take, we can measure in-time assessment that we can take that can facilitate our understanding of presenting symptoms, how patients are doing over the course of treatment, and therefore tailor care to increase outcome. And we know that, there's ample evidence that people who are wearing their smartwatches, for example, are exercising more. Even by wearing that device, it's some type of, passive intervention. And it's there. So how do we go about understand digitalizing healthcare? The AI, when you look at artificial intelligence, it can be a very complex to understand, but it's very, of course, artificial intelligence is complex, but it's evident in everything that we do. It's pretty much a combination of technologies that really, technology and tasks based on certain codes, certain algorithm that predict various models of behavior. So it pulls information, for example, from an expert system that really inform decisions. So if we have this type of label data, we have these type of construct, therefore the risk is, we see these risks there for the patient, that could trigger tailored intervention treatment based on these risks. And I'll go over this a little bit more, how it's done within different platforms.
Maria, I don't know if you want to stop a second. You have a couple of comments in the chat. Do you want to hold those, or do you want to finish?
I'd rather just finish and then we can have a conversation.
Okay, great.
Okay. Yeah, can't wait to converse with you with all the questions. Keep them coming. So AI is really evident with everything that we do. Think about, well, if you are searching the web, you go to a certain web page and different web pages. And by the time, or you go to your groceries and you made certain purchases. And by the time next time you're online and you might be doing a search that is unrelated to purchases, and you see various recommendations based on the pattern of this passive data collection that is happening, that, based on your pattern of purchase, based on your search queries, that you get these recommendations. This is part of AI. Some AIs are more complex than others, but everything that we do, especially in using technology, potentially your information is being collected. Not to, worry you, but within the context of healthcare, it's an opportunity to really help gather, relevant data that can help us provide more finite treatment. So increasing access. So how could we increase access with mobile phone apps? So leveraging clinical assessment, especially in an environment that in low resource environment. So we can have apps be part of psychiatric care where patients are completing assessment, downloading the app, completing assessments, and therefore that information is being used to triage who is in most need of immediate care. One way this could be done, it's not just one assessment. For example, in clinicians in those people are clinicians are aware of the Beck depression inventory. One way we determine the risk for suicide is that if you have a total score that is higher to 31, and then on this scale, there's an item that really clearly asks about suicidality. If your answer is 2 to 3, this is an indication that you might be at risk for suicide. So that in low resource communities, low resource healthcare centers, that could be a way to help move along, have people move along the assessment process, because assessment is really important before you start treatment, because we have to know what we're treating. But if you're doing it in a way that through an app, you essentially can eliminate the time people are waiting to see an in-person clinician. And psychoeducation could be one way to deliver for apps can be used to deliver psychoeducation, which is really important in healthcare, especially with newly diagnosed patients. They do not understand their symptomology, their experiences. And oftentimes as clinicians, we spend a lot of time explaining various symptoms, various experiences in the context of the disorder for the person. Understanding, explaining the symptomology of panic disorder for somebody who's just newly diagnosed, who feels like they are having a heart attack, can help them manage the disorder better. Because if you know you're not having a heart attack, therefore not increased risk of dying, that could really reduce your level of how panicked you are. So increasing access, translation of evidence-based treatment. Earlier I mentioned there's about over 400 apps, mental health apps. Most of these apps, almost all of these apps are not based on evidence-based approaches. We need to make sure that we're not giving access to just treatment, but to quality treatment. So how do we have manualized treatment that have shown to rigorous scientific testing to shown to be effective? How do we translate them into app platform, and where we streamline these information, the symptomology and construct that has shown to underline change and improvement, and provide and have patient access these type of treatment. These programs can be self-paced or time constrained. Self-paced can be actually even much more helpful for patients who are newly diagnosed, patients who are depressed, who feel like even, opening a computer can feel like a task. Being able to do it on your own may take the time burden they feel like they have to complete at a certain time. And we have, there's certain features within apps, electronic diaries, monitoring of symptoms is a really important aspect of treatment. And allowing easy monitoring of symptoms through voice dictation can really help us to think, okay, what are some patterns we're seeing across time here? And how do we formulate treatment to address these patterns? So what is the scientific support for apps? Because whatever we go into, if we're talking about quality care, we have to say, okay, if we're going to use this platform for dissemination of care, therefore increasing access to quality care. So what is the scientific approach? So support. So we know there's a high interest in health, in app-based health programs. And we know that ease of access is one of the reasons that why a lot of patients or participants, if it's within a research context, are interested in this. And there's ample information, there's empirical evidence to show their significance in decreasing depression symptoms. And also we see effect size, a large effect size. We see the intervention effect comparing smartphone-based programs to non-smartphone, and we're seeing that the smartphone has a larger impact in terms of outcome. Although there has been a few randomized control trial, and I wanted to explain randomized control trial is this golden standard in which we determine effectiveness of an intervention, of a program, right? We have to, if we say, okay, what we have here, we have the standard, and now we have something new, we have to determine whether this is better or more effective to the current intervention, or to a control, to a non-treatment control. So the pilot randomized trial, there's been some pilot randomized trials that have looked at smartphone. In the randomized trials also, there are really stringent guidelines for making sure that you have comparable participants, similar participants in the same condition, the treatment, the smartphone condition versus the non-smartphone treatment, to make sure that you're not comparing apples to oranges, or you're not having one group that has so much elevated anxiety symptoms and the other group doesn't have it. So you have, so you're making sure that the patient population that you have in there is pretty comparable. So attention to language. How can we utilize technology to address the problems that we have within mental health and assessment and in treatment, which means, okay, how do we assess, pay attention to language and meaning of language that could really help us to better inform treatment? hallmark, psychiatric symptoms and construct of them. And I was having a conversation a long time ago with one of the CUNY psychology CUNY, that these symptoms are not different. The features of psychiatric symptoms are not just different for different groups. It's just they might be present in unique ways for different groups. So what we see in the literature is overdiagnosed of African Americans and certain other groups with somatic symptom disorder. Somatic symptoms disorder is basically report being sluggish, headaches, so various some physiological symptoms that are being presented that can actually be associated, that we have seen are associated with actually major depressive disorder. But in certain clinical setting, when somatic symptoms are reported and not the psychological hallmark of depression, feeling down, feeling low, suicidal ideation, major depressive symptoms for some reason are not explored in certain of these settings. So you have, mixed diagnosis of patients and therefore untreated disorders are there. So patients are graded untreated. There's some clinical evidence, and I have to say the next one, looking at Haitian women in terms of postpartum depression, that the language that a certain subgroup of Haitian women use to describe what we know now is postpartum depression is that they talk about in the context of a dysfunction of the breast milk. That something about the breast, the physiology of the breast milk is not working. Therefore, their symptoms of feeling depressed, their symptoms, depression is not used, of feeling low energy, of not bonding with their child, having some psychotic symptoms, because psychosis can happen within postpartum depression, is a result of that. So think about one of the researchers who's in this field. What he found is that the vernacular for explaining this dysfunction is and I apologize for anybody who is a Creole speaker, because this word this is more of a French word rather than Creole word. I was trying to get the computer to do this, but it would just not go. Let monteo means that the milk went straight to your head. If you had verbatim translation, that's what it would mean. But if you were to do that, verbatim translation misses the meaning of it. Because when you talk to these patients, the symptoms that they are reporting, their experiences, it's consistent with postpartum depression. So what we're missing in mental health, it's not just, people have access to translators that are really wonderful, have access to people from their own background, but also meaning. What does that mean for that patient, and how do we pay attention to language? So how could we use technology to do this? We can do this by leveraging qualitative assessment. Now we use only quantitative measures, but we can also use qualitative options where we ask patients to talk about their experience, not their symptoms, but their experience, and utilize various models, develop models, label data, and feed, that we can use to identify clusters of presentation, clusters of symptoms, and how these clusters can be used to inform care. Another options, and I be mindful of the time, is robots. Relational agents are being used. They're computerized characters that really look at very human-like. They interact with you, they joke with you, they remember information that you have done. You have done based on surveys that you do. So when you're part of a relational agent delivered mental health, the interaction is supposed to mimic a human interaction. And I've also, in graduate school, actually tested various relational agents as part of my dissertation. So we see the efficacy of these platforms in augmenting care and treating schizophrenia, for example, and other disorders like anxiety. And we know participants are receptive to these platforms because we have to make sure participants are receptive and feel like, okay, this is actually a trustworthy platform. Therefore, the recommendation, the feedback for care, I am going to trust it. And some patients actually prefer the relational agent instead of a human counselor. Relational agents overall are the goal is to have this part of healthcare, but we know, and while it's costly to develop, it might be costly to implement, but overall, when you do cost analysis over time in comparison to the number of people you need, staff, and time you need to disseminate mental health care to depending on the population of the community, we see cost analysis overall. The relational agent is actually very optimal. However, there's some setting that relational agent, because they can be costly, they're not feasible. What is being utilized now is chatbot. Chatbots, the good thing about it is that there's some computerized interaction, computerized interactive robot that's interacting with you. And why this is important, because the interaction is important. When we see text-based, if you are part of a text-based mental health intervention, where we're seeing over time there's low engagement, because that interactive nature of the robot, of seeing the robot, we've seen that it has shown to be related with interest and consistent regular engagement and care. So as we move through mental health and looking at the status of mental health, as I mentioned earlier, better assessment allow us to really do better understand the pattern of behavior and predict overall mental health. However, how we're collecting data right now, we may not be getting great data to inform treatment. So we are using, all of these various technologies. People are using technologies, sensors, geolocation, search histories. These are part of our interaction rather with technologies that can really provide us with viable data of understanding symptoms and therefore intervention. For example, take sensor data through a Fitbit that you're wearing that I'm showing right now. I have a Fitbit Versa 2, I believe. And through LED lights, the green light that is flashing, LED light that's flashing into your skin, you're getting biomarkers data, such as your heart rate. So let's say one way this is being done in certain area of research, and hopefully the goal is to integrate this within clinical setting. And that's being done a small level, a small scale in clinical settings, that you have a patient's heart rate through data, through a collection of data, you have developed a phenotype. So a phenotype, think about within a clinical context. When we're treating a participant, before we treat them, we get ideal is that we get information from various sources to develop a clinical profile that shows development, factors that led to the development or onset of the disorder, factors that contribute to the maintenance of the disorder. So how to tackle these various factors and what strategies that are more effective. So we have all of this information. So how it relates to phenotyping is the same thing, that we're getting all of this data, and what we are using basically is to develop a pattern. We are developing a pattern, and then for that participant, and based on that, when we see their heart rate is elevated and consistent with normal pattern, that can trigger ecological assessment. Ecological assessment is basically an in-time assessment where you are, where we could collect data on various factors, stimuli and behaviors that occur close in time, and therefore we can deliver intervention that address these maladaptive thoughts and behaviors. So another area of ways that phenotyping is being used, for example, we see here that, somebody if you're targeting excessive alcohol use, depending on information you've had in this participant that help you also address or identify a risk profile based on where they are and their other risks. You can therefore deliver an intervention, not only that will alert them of the risk, but they're also providing information about what they could do to decrease excessive drinking. Identify and potentially phenotyping can identify triggers, temporal triggers. What are the same triggers that you have? Are they the same at home versus at work? Or when we map these patterns, do we see that they differ during the week or the weekends? So now we have all of this information. One way we could, because we talk about, we have all of this data, how do we make sure that providers have access to this, all of this information that could essentially provide care? So digital blockchain is one way. It's a centralized way. It's not a technology per se. It's a centralized way where you can actually store all data and providers can have access to data that really remove the third party where you have to get consents, faxed over the consent to get data, your patient information. You have all information in a centralized way, and the block, and it connects. You can have various blocks for various metadata, and the amount of data, metadata, it's a huge amount of data, whether it's treatment history, personal history, various treatments that you're using. It could be history from ever since you started going to various providers. That could really inform us. Provide easy access of information. And within that, you have an ecosystem where you don't need to call the psychologist if you're the PCP, or call the PCP of the psychologist, because you have access to care. So why is it important? Because it's going to be adequate intervention. It's going to prevent inadequate intervention, as we see that can usually lead, that will lead to frustration and eventual attrition. So you have information, centralized information that is transparent, information that is clear, that could potentially help you to inform care. So in blockchains, how it's being used, it has great implication of helping us to understand etiology of various psychiatric disorders. For example, we know there's some abnormal, the chromosomal abnormalities for people with schizophrenia, that the 22q11 gene, there's some abnormalities in small, that have been shown in small sample with people with schizophrenia. That's a way to increase, with that amount of data, that metadata, we can really understand, really have an established understanding of various technology, various factors that are impacting the disorder, and therefore develop prevention. Even though right now public health is not a prevention, it's not a primary prevention programs, it's more tertiary, where people already have disorder and we intervene, but we can identify people that are at most risk for this disorder and intervene, which is really important to decrease human suffering. So, but there's some limitations here that, wide integration of various technologies, for example, require that we have certain multidisciplinary team. We require that, that we think about how we're going to integrate technologies to existing system, and having people learn different type of technology they may not actually care to. I mean, and data ownership is something that you always have to talk about. Who owns the data? If it's in a decentralized way, although a lot of around who make it a clear, transparent who owns the data using blockchain platforms and various apps, that is being, the guidelines are being developed, although, there's not a standard way across how it should be done. Large randomized trials is needed, because as I said, there have been small pilot trials, but these are very small samples. So we need large trials to assess effectiveness of these technology-based approaches. And technology, not because somebody owns a mobile phone does not mean a group have high saturation, ubiquity of mobile phone ownership does not mean you can just develop a mobile phone health program and just give it to them, because technology alone does not change behavior. We still have to look at the content and getting information that could help us to tailor treatment for these individuals. And there are some groups with cognitive deficiency that technology alone may not be appropriate way to disseminate treatment. What can technology do for us? It could really, way we interact with the world can really gives us information about, about what are some underlying factors that are presenting, that are interactive and presenting symptoms, and therefore should be addressed in care. As I mentioned, web page, what we already do these things. This is not burdening participants. This is information that we already do. How do we tap into the available resources to really pull out information that could really help us expand our understanding of mental health disorders and therefore treatment? And revolutionize how we treat psychiatric disorders, and more importantly, prevent the onset of various diseases. Here are some references. If you're interested, I can send it to you. And I thank you very much for your time.
Thank you so much. That was incredible. Susan, did you want to ask your question and unmic? So the question was, can you please clarify again what the limitations to therapy are? And is it financial, physical, or time management?
Well, the limitation that we address in this talk is access. Access to care, access to evidence-based care, and within evidence-based care, how do we address language, culture, and meaning that have shown to impact how we assess mental health disorders, how we diagnose them. And then we address integrative, the barriers that we have, because we have providers essentially working in silos that are not, we don't have access to each other's information, therefore we do not have integrative care. So whenever you see a patient with psychiatric disorder, they have other providers. They potentially have other pertinent information that can help you formulate how you develop a treatment plan. The way that the mental health treatment is right now, we do these barriers, we have to better address them, and technology, very relevant technology could help us do that. Financial issues is absolutely an important aspect to barriers, but if you have evidence-based treatment that is delivered through an app, that could reduce the financial burden of having participants paying copays. Maybe that the access to that treatment is at a lower cost. These are things we have to iron out within mental health. Again, we have these viable platform. However, this is still being, we need more research in some aspects of it to see, okay, how to integrate these things in care.
Thank you. And there's a follow-up. I'm wondering, are these technologies used in conjunction with therapy or intended for a replacement of live therapy? How do you integrate connection with a real person who cares, which is a very important part of therapy?
That's another good question. So I'm reading the question because there's several parts to it. So I want to make sure, Suzanne, I answer them. In conjunction to therapy, I think in certain population, it has to be adjunctive to therapy, right? To in-person therapy. So let's say that you see your therapist weekly or bi-weekly, you can have the person still be enrolled in an evidence-based mental health treatment that they can access on their own. Because think about it, how we deal with life, right? So, people deal with life daily, right? There are emerging barriers that a therapist is not there, here and there to help you address. So having that access to that treatment, so by the time I see you on Wednesday, the issue is no longer at the intensity it was. So had I intervened on Monday when it happened here and there, intervention would have been much more effective, much more appropriate, much more tailored, right? So there are groups where it's going to be adjunctive to therapy. The second part of the question, how do we integrate a connection to a real person who cares? Okay. Relational agents, while I say that, these are computerized characters that are developed to mimic human interaction, share that they care by showing empathy, and they use various gestures, and their features are pretty human-like. It's not like these weird robots. They're very, they look essentially like human. Of course, you do know they're not human. That mimic of no robot, at least not now, or no computerized health coach is going to replace human connection. However, you can mimic it. You can help it being close to it, because we are talking about access. We are talking about people. Psychiatric disorders have the same impact. Untreated psychiatric disorders have the same impact as medical disorders on functioning. We want to make sure people are accessing treatment, and we want to make sure that what we're giving them is consistent with this human interaction we see in it. How do we teach a robot to do that? So how you do that is through multidisciplinary collaboration with psychologists, with other engineering to help to do that. But will it ever? No. The goal is not to replace human, it's to enhance therapy, it's to augment therapy in a way that there is easy access. The last part of this question, how do you integrate? Oh yes, well, I guess I answered the last part. The goal is not to, and the evidence is there. There's some who actually prefer the computerized health coach, relates to it better versus a human coach, a human counselor. Oh, you're welcome. Levin had his, I'm sure his or they, I apologize if I'm using the wrong pronoun.
Hi, yes.
Hi.
My question is, you covered a lot of topics. I'm trying to integrate it. I guess I see the potential for these technologies. I'm still looking at it, but I see it as more of like a reform and a way to bring in perhaps more health equity. But I don't see it as a real revolutionary upstream kind of change addressing the problems with, biomedical approach to medicine that we have, and other issues related to the mind-body split and all of that, and also the concerns about AI, of course, ethically and other ways are great. So my question is, do you think it has that potential? Or for me, there seems to be more potential for big change in the use of psychedelic therapy, because it's showing the potential to be possibly curative, and also it's impacting at a much deeper level, and therefore it's going more to the source of the problem, whether it's depression or trauma or all the things that they're testing these in a evidence-based manner. So do you see a potential use for psychedelic treatments, and do you see a difference in the potential outcomes, one being more dynamic and sort of revolutionary, and the other being more about trying to improve the system as it is?
That's a great question. I'll try my best to answer each component. If I don't, please remind me. So the revolutionary part of it is that we have the opportunities to have data, and we have to have data with biomarkers because we're not with sensor data, as I mentioned over. With sensor data, we have moment to moment opportunities to collect that data that within the context of mental health that can really help us to see how patients are doing with their anxiety symptoms, in addition to self-report. So, because we know whether in research, whether in the healthcare setting, self-report data is not the most reliable. It's not because the patient is lying. It's because it's self-report. People have other things to do. They're not sitting there and logging their symptoms. So we have a passive way to do that. Another way is revolutionary, adherence to medication, to various chronic conditions that impact psychiatric population more so than the general population. For example, now there's a sensor, medication adherence to, for example, type 2 diabetes, and it's going into HIV, where there's a sensor within the pill that you're not asking patients whether they take their medication. You can know when they take the medication and how they're taking the medication. So we have all of these ways to collect data and not burden a patient to, did you take this? Did you do this? Do that? By having that information, we can intervene appropriately. So I think it's revolutionary in a way that it's providing us access to information we do not have, information we know that probably have impacted the way we deliver care. And I'm sorry, what was there was another part to this.
If the psychedelic therapeutic treatments, I see the potential as much more revolutionary because of the way that they work and how the results that are coming in on the studies, that MAPS and others are doing.
Yeah, I think that's also a big and could make a really big impact, because we're seeing the mapping, being able to map patterns and developing a phenotype for the patient. And that includes various risk factors. As a result, we can intervene when there's a deviation based on that pattern, intervene at the risk level that really prevent engagement in various behaviors that could really impact mental health. So yes, I do see it revolutionary, but I don't think technology, like I said, is going to answer questions, it's going to promote behavior, mental health improvement, but we have systems that exist. We have various treatment that exists. We have platforms that can augment access, where we can we can collect data that further refine how we intervene. And this is where technology really can augment care and outcome.
Thank you.
You're welcome.
Thank you. Are there any other questions?
If you have any questions, you can also email me, and
we'll be sure to send that out afterwards. If everyone would please be so kind as to complete our survey. I want to thank you again. This conversation has been more than interesting. I have all kinds of thoughts about new projects, about new ways that we can bring information to the community. So I thank you for your time and your energy and your commitment to helping us better understand this process.
Well, thank you for inviting me, and thank you very much for your collaboration and your help. You've been
My pleasure. Thank you, everyone, for attending. We will be, again, having some additional workshops that'll be coming up. You can find us on Facebook. You can find us on Instagram. We're also on LinkedIn. We'll be sure to send out our upcoming events. We have one on June 3rd, measuring managing performance, why establishing performance management systems are good. That will be at 12 noon. And then for Pride, we are working on a series called The Ballroom Has Something to Say About Being Human and the Struggle for Freedom in the Face of Catastrophe. And we will be joined by Dr. Jennifer Lee, who is an alumni, who will be convening those conversations. So thank you again, and we will send the link out as soon as this recording is over. I will stay on a few minutes longer for those that need to fill out their survey. And thank you, and have a great day. Thank you.
Okay. I'll stay on just, oh, okay.